this month clinical meeting. For a change, we have split the departments, so we'll see this as a test meet. So usually I call our consultants to deliver a lecture, and today I invite myself for the talk on case capsules. It's going to be really highlights and going to be really fast because we have 3 sessions lined up, and I don't make second slide of any of my presentation because this is by default, and we dedicate all our talks to our great mentors who made us to stand like this in front of you. And I'm very happy to say that the NAPCON 2024 is going to be held at Coimbatore, and the interstitial lung disease workshop is going to be held at our hospital. And we have cream of people coming to ILD workshop at Ramakrishna who have readily agreed to visit, right? Starting from Professor Randeep Guleria up to the Dr. Ashutosh, we call her as Queen of Thoracic Radiology in the country, Dr. Deepak Talwar, Shitu Singh. So many people are coming, and my mentor. So I always talk to them before I start. So this is Mrs. V, 14-year-old lady, is a relative of the professor of neurology at CMC Vellore, came to us for evaluation of the lung disease, and she was asymptomatic except grade 2 breathlessness. She went to cardiology, and the cardiologist told something. I'll tell you the story. So this is the chest X-ray which shows the mass lesion in the right lower zone, and this is the CT which shows the mass lesion in the right lower lobe abutting the subcranial area, narrowing of the right main bronchus, and you have the lesion here. Okay, so something is protruding into the left atrium, and this patient went to cardiologist, and cardiologist, the initial impression was left atrial myxoma. She was referred for surgery, and she referred the case to us, and finally when we started evaluating, it was something else. So patient got desaturated, and we were talking, and the saturation went down to the 60s, 70s. She was getting arrested in front of us. I think that Ramya was there sometime before she left for the talk. She was the anesthetist. She got arrested. Patient got arrested, and CPR was ongoing. And we started debulking the lesion in the right main bronchus. So right main bronchus. So she had actually had a central airway obstruction. And if you see the mass lesion, it is traversing the pulmonary vein, which drains into the left atrium via the pulmonary vein. It was traversing, the tumor was traversing via the pulmonary vein into the left atrium, mimicking like left atrial myxoma. So patient got debulked on table, prolonged CPR, procedure took 2 hours, and she went home without any neurodeficits. And this was the echo images, which one could, I think Nandakumar is here, so one could easily say that it is left atrial myxoma in an age like that, but it was a mass in the right lung, which travels via the pulmonary vein, and because the pulmonary vein drains into the LA, and it followed the route of the pulmonary vein and entered into the LA, mimicking like left atrial myxoma. And you can see the sagittal views, which also says the picture which I was dealing with. So this was a high-grade high-grade leiomyosarcoma from the right main bronchus. It was a rare endobronchial tumor. And 2 hours prolonged procedure, prolonged CPR. She went home, she walked, she lived 2 years, and 2 years later, Dr. Gogan treated this patient later on. Chemotherapy. She took chemo, and this was one of the chest X-ray. Can you ever believe the high-grade leiomyosarcoma having chest X-ray like this 1.5 years after the procedure? Patient was under Dr. Gogan's follow-up, and subsequently she succumbed 2 years later and given the malignancy. So this lady, 76-year-old lady, Mrs. B, came to us with for a pre-op evaluation. Actually, this patient was posted for.
Sorry, one minute.
Yes, sir.
This atrial myxoma, that's also removed in the same sitting? Myxoma-like?
Myxoma-like, the picture was not removed. No, this was, patient did not undergo surgery because it was a bronchoscopy debulking. Debulking of the central airways. We could not clear the subsegmental areas because the idea is to do the minimum to save the patient. Because she got arrested. Prolonged CPR, 2 anesthetists were there. So we could remove the tracheal mass, right main bronchus mass, idea is to keep the patient alive, and we shifted the patient to ICU. Later on, all those things got melted with the chemo. Subsequently, images were not available. Probably the recurrence, and that's the information we got from Professor Sankita. She is the professor of neurology at CMC Vellore. So this is 76-year-old lady was posted for total knee replacement. On the table, anesthetist found that patient had desaturation, unexplained desaturation in an asymptomatic patient. So surgery was cancelled, patient was referred to us. If you see the chest X-ray, there was something sitting there. So patient asymptomatic, significant desaturation, otherwise normal patient. Diagnosis is very few in pulmonary medicine. I'll tell you what it is. So this is the CT. Actually, this patient was referred for the biopsy, the deferred biopsy, and this was the CT. You can see the aneurysm sitting there, and it caused significant right to left shunt, producing desaturation in an asymptomatic patient. So these are the images, and you see the huge aneurysm sac and being embolized with a device by Dr. Mutturaj, and this is the endovascular device embolization, which completely collapsed the wall and saturation picked up. Subsequently, she underwent surgery. So, asymptomatic patient, desaturation, mass lake lesion, suspect pulmonary AVM. So, this patient, 30-year-old male, asthmatic, had fever, cough, breathlessness, loss of weight, went to outside, chest X-ray showed lesions, bilateral lesions, consolidation. They thought it is tuberculosis. They thought it is drug-resistant, tuberculosis. Initially, drug-sensitive TB, DRTB, treated, no improvement. Came to us with a label of difficult asthma. So this was the chest X-ray, and you can see finger and glove appearance, toothpaste-like lesions on both sides of chest X-ray. It was very classical of allergic bronchopulmonary aspergillosis. Studies of varying severity have shown that incidence as high as 40% in those patients of asthma who present in ICU with respiratory failure. So any asthmatic required screening for ABPA, and this patient actually had respiratory failure, have to undergo bronchoscopy for removing all the mucus plugs, and these are some of the mucus plugs which we saw, which we removed, and post procedure you can see the chest X-ray patient improved and got extubated. So suspect ABPA in any patient who has difficult to treat asthma. Elderly lady, massive hemoptysis, mother of the army major in our Indian army, came with history of massive hemoptysis, and you see the CT. I don't have contrast CT now, and CT was deceptively normal looking CT. Always requires a bronchoscopy rule out endoluminal pathology. You can see it tends to put your forceps inside, and if you put, and that is the end of the day for you. This is endobronchial diaphragm malformation, AV malformation, systemic circulation. This is, Dr. I think Dr. Professor is there, he was anesthetist, and we got coagulated with the organ plasma coagulation. Initially, these patients undergo lobectomy, and with the advent of the kind of instruments that we have in the practice now, these patients can undergo the definite treatment without the surgical treatment. So that was an endobronchial diaphragm malformation, which can profusely can bleed, can be a very nightmare for a bronchoscopist if it touch that lesion. So all massive hemoptysis need not require surgery, and you can offer the definite treatment with the kind of instruments that are available now. This patient came with pneumonia, bilateral pneumonia, ARDS, treated, pumped with all antibiotics, did not improve. So fancy antibiotics, high costly antibiotics need not be answered always in lung, always in medicine. We need to look at what is known as the differential diagnosis. The CT, this is not pneumonia at all. The CT itself shows that it's not an infectious process, it is something else, typical crazy paving appearance. Patient underwent bronchoscopy, and this is the finding that which we saw, serially increasing hemorrhagic return in the same segment lavage, which is pathognomic of diffuse alveolar hemorrhage. Instead of pumping with an antibiotic, this is a case of diffuse alveolar hemorrhage, it turned to be systemic vasculitis, melted with methylprednisolone. So all acute bilateral lung shadows need not be pneumonias. Always we need to, as a matter of fact, lung disease, apart from the bullous and pneumothorax, all presents with white shadows. And it is our duty to find out what has led to the white shadow to the presenting patient. And this is one of our patient, hemoptysis, poorly controlled diabetes, right lower lobe cavity, you can give differential diagnosis. Patient underwent bronchoscopy, there was a globular lesion which we saw in the right lower lobe, and biopsy it turned to be, mucormycosis. Mucormycosis, patient underwent surgery, and these are some of the resected specimens. Pathologists are very happy to cut the specimen when they give large specimen. I think these are the images from Dr. Veena, and this turned to be mucormycosis. Mucormycosis. These are the not unconventional treatment that you can give in patients with mucor when they don't when they are not willing for surgery. This is one of the papers which is published in Lung India. And this is the patient. This is Dr. Vikram's patient. The referral was given for the non-resolving pneumonia. Non-resolving pneumonia. Any PGs or a quick comment on this chest X-ray? Medicine postgraduates. Okay, there is pneumonia. There is tube, you can see. Quick comment. We'll carry the price at the end of the day. Okay, so I'll read it for you. There is something is sitting there in the right lower lobe bronchus. So that in the appearance you can see there is a teeth which has blocked the right lower lobe bronchus, has caused persistent pneumonia in an intensive care unit. So that we could remove it, and this is the teeth. It's not about the story of removing the teeth. It's the story how it went into inside a patient who has tracheostomy tube with a cuff inflated stage. Okay, so we are putting so much stories, nobody is accepting our stories, So there was a tracheostomy. Before the tracheostomy, there was no teeth. Believe me, there was no the teeth in the chest X-ray. Patient had tracheostomy, and there was cough, and teeth were going inside. So this happens, and last week also couple of weeks also we had teeth above the tracheostomy tube. So one has to be very open. Foreign body can find the root if there is a root. So middle-aged male came with recurrent hemoptysis.
How this went inside?
That was, we are trying to postulate stories. So it's a hypothesis. That's why I put the word hypothesis.
Inflated. Then how tooth can enter into the trachea?
$1 million question, sir. I don't have any answer. I always give theories on this when I present this, and I always say, sister has deflated the cup. At that time, tooth has to get loosened. It has to fall down. So many theories we can say. At the end of the day, we don't know. But it was there. But I went to all the images. We have the chest X-ray prior to the tracheostomy. That during intubation would have loosened, teeth would have loosened. But I checked the pre-tracheostomy chest X-ray. There are no teeth in the chest X-ray. Maybe in the oral cavity, kind of thing. Definitely would have dislodged. Otherwise, it would not have gone inside. So this is a middle-aged male came with recurrent hemoptysis. All investigation was normal, and underwent bronchoscopy. We could remove this ground nut, and he came very recently, also a couple of weeks. He lives in abroad. His job is, used to that time was an IPL season. He used to put the ground nut like this, and he used to see the teams matches. So it went inside, and he could not see the rest of the IPL matches, and that was the hemoptysis due to ground nut aspiration to the right main bronchus. This is a relative of one of our own faculty, they came with non-resolving pneumonia, persistent consolidation, bilateral, upper lobe dominant, and did not go away even with any kind of treatment. So all these lesions requires an answer called biopsy. This turned to be the low-grade Hodgkin's lymphoma, which was marginal zone, and patient subsequently got treated. So this was lying there for nearly 2 years. So you can have lesions for years together, especially when they are low-grade malignancies. This patient, I think Mutturaj is behind, will be remembering this patient, came with breathlessness and cough and leg pain, and there was a pleural effusion, and the answer for breathlessness was pulmonary embolism. It did not stop there. And patient had extensive thrombus up to the lower, the vasculature, the lower extremities, entire IVs was floating with thrombus. And he had recurrence even on treatment. He had actually, the images are missing here. He has a mass-like lesion in the right lower lobe, which we biopsied, don't be tuberculosis, took ATT. Rest of the workup, repeated workup for pulmonary embolism was negative. But this patient ultimately required, the IVC filter for recurrence. You can see the thrombus here up to the lower level, and this is one of the IVC filter that you can offer in those patients who develop and who recur thrombotic tendencies on optimal medical management, ruling out other secondary etiologies. So this is a patient came with cough and fever. Next patient, middle-aged female, bilateral lung nodules, halocene positive, and treated as tuberculosis outside. And biopsy came as vasculitis. This was GPA. And this was one of the recent patient couple of weeks before. This patient also was treated as pneumonia in ICUs, pumped with antibiotics. You name any antibiotics you receive. And this is Dr. Muruge's patient. So at the first insult itself, it was not pneumonia at all. This is something else. This is vasculitis straight away. He did a biopsy. It turned to be vaginous. And I thank Dr. Veena for sending all these images at the whenever we ask. So this is the blood vessel. This has produced granulomatous vasculitis. You see blood vessel with the granulomatous inflammation in the wall. These are small arrows. I will not take you to your histopathology class. If you are very much interested students, Dr. Veena is sitting behind you, so you can ask her. See, this is the internal elastic and external elastic lamina, which is she highlighted with the Pangistan stain. And also the highlights the angiocentric inflammation of all these lesions. So one of the causes for granulomas in the lung is vasculitis in a given situation. So that's the message out of this case. You can see the Langerhans cells with granulomatous inflammation here, and also she had mentioned the infantile type of necrosis which you see in patients with systemic vasculitis. Actually, this patient is doing well, and the lesions are melting away now. This is an elderly lady came with chronic cough and weight loss. You see shadows on both lungs, and these are the subpleural dominant consolidation. This patient also treated as pneumonia. Pneumonia did not improve. Subsequently was given ATT, and that seems to be answer for all lung disease, And actually, it is not. Biopsy came as the organizing pneumonia. Evaluation showed rheumatoid arthritis. The lung manifestations of rheumatoid arthritis can occur as high as years before the manifestation of the joint disease. I remember one of the army major who was diagnosed as bronchiectasis in 1989. He is still coming. That time the serological test was positive for rheumatoid. In 2023 he developed rheumatoid arthritis manifestations in the joints. He's an army major, and the medicine is peculiar to present all this fancy way of presenting disease. This is a middle-aged male who came with hemoptysis and lesion in the right lower lobe. I think Krishna might be remembering this patient. Underwent PET. PET showed high uptake FDG lesion in the right lower lobe. Dr. Nageshan sir also here. We might be remembering this patient. Very recent case. Underwent biopsy. Biopsy showed organizing inflammation with actinomycosis. We should compliment the department of the pathology to picking up this. If somebody says it's actinomycosis, right after putting this CT, then they got a flu outside. So that's how we treat our students. You see, the same kind of patient was presented in one of the national conference. Last couple of weeks before, actinomycosis presenting as mass lesion. So you see, this all comes from the pathologist. We compliment Veena and Dr. Sethu for picking up this. And these are thrombosed blood vessel with inflammation. Patient took treatment. This is the follow-up PET CT, which was thought to be malignant. No more malignant. Lucky patient at the end of the day. Dr. Suresh is here. His patient is this. So this patient is a case of actinomycosis, pulmonary actinomycosis, presenting with hemoptysis. So this is a patient, young female, came with fever, and you see necrotic lesions in mediastinum, and this is the EBUS shows the heterogeneous lymph node. We sampled it, and these are the pus kind of lesion that you can see in subcarinal left hilar region, and this is a nearly percent turned to be tuberculosis. So you have answer nowadays for all the lesions which present to you. So middle-aged male came with chronic cough. Very recent case, the police officer came with chronic cough, relentless cough. See, he was on AC inhibitors. We stopped AC inhibitors, but it's not the cause. AC inhibitors is not the cause of cough because you have lesion in the chest X-ray. There was bilateral the lymph nodes on both sides and underwent EBUS. It turned to be granulomatous inflammation. These are the EBUS nodes showing granulomas. This is a bronchial biopsy, granulomas. This is a case of sarcoidosis. We see less sarcoid in South India than North India because of racial difference, but still it exists. So these are some of the samples that which we get through EBUS tDNA. You can aspirate pus, you can get nice scores, which the pathologist will be very happy to process all these samples. You see, through the EBUS methods. So the middle-aged male, next patient came with a right lung mass. We thought it is primary lung malignancy or something else. This is the lesion in the CT. You can see the right paratracheal subcarinal, left paratracheal node, and this is a heterogeneous node. Once you start seeing these kind of images in EBUS, then malignancy comes high in cord. Actually, this patient had endobronchial lesion. We biopsied it turned to be carcinoma. It was renal cell carcinoma. It was metastatic renal cell carcinoma into the endobronchial region. So nowadays we have radial EBUS. So you can go into the lung parenchyma. You can see the heterogeneity of the signals to sample from where the pathology is. And this is one of the patients which we recently did turn to be eosinophilic pneumonias. So instead of targeting the lesion very plainly, you can pinpointly you can target the lesion to get the answer what you want at the end of the day. It's an young male, left pleural effusion, relative of one of the dean of this state medical college, came with diagnosis of tuberculous pleural effusion, very high ADA 150. Underwent thoracoscopy, you can see lesions like this. Once you see lesion like this, then it tells away from tuberculosis. This was turned to be T lymphoblastic leukemia. Actually, this was patient. There was a huge argument that why don't you put these patients on ATT when the ADA is very high. So ADA very high need not answer that this is tuberculosis. This is sensitive but not specific. As far as when there are patients who died of treating these patients as tuberculosis, even in doctors. One of the patient high-grade B-cell lymphoma we published in Lung India that the physician took ATT because the ADA was 150. Finally turned to be high-grade diffuse large B-cell lymphoma. And so that's the story at the end of the day. So the high ADA need not be an answer to treat the patient with ATT. These are some of the...
So this lymphoma on the lung.
That was the pleura.
The pleura. Did you look for lymph nodes?
No. There was not. Sometimes we see, sir. So this is actually if there is we don't do thoracoscopy or invasive procedure when there is a lesion outside to sample very easily. But this patient never had any lymph nodes anywhere. The presentation is only the pleural effusion. Even if you see in the mediastinal valve, there are no nodes.
No, why am I asking this? We do see case of B-cell lymphoma of the brain, which is involved as well as some lesion of the lung.
Yes, sir. But it is the other way around. Maybe we can follow up this patient, but there is no, because we are not following up this patient for evolution of the disease. Because once you hit the lesion, you get the diagnosis, we always treat the patient. So we are not allowing the patient to develop a natural history, but this patient did not have a lesion elsewhere, only pleural pathology.
Brain was clean.
Brain was not screened because there are no symptoms and focal signs.
What PET is used to put that?
PET is negative, except the uptake in the pleura. Yes, PET is negative. This patient is taking treatment actually this patient his marriage was due for 2 months later when he was diagnosed. And PET was negative except the uptake in the pleura. So this is some of the thoracoscopic images that we do in patients with pneumothorax. You can insufflate the towel for the good pleurodesis here, and this is some of the times. Sometimes we do this whenever there is a patient who is willing to undergo towel pleurodesis. So pneumothorax, post pneumothorax always requires some definitive procedure to prevent the recurrence. It's a towel inside the pleura. And you can see the bullas inside the lung once you open up the pleura. When you visualize thoracoscopy, you can see all these images. So these are some of our pictures of the answers for the unexplained pleural effusion of undiagnosed etiology, the adenocarcinoma, squamous cell carcinoma, adenocarcinoma, small cell carcinoma. So this is the visceral pleural infiltration of one of our patient. You can see notice another patient. This is how the pleural tuberculosis looks like in pleura in thoracoscopy. diffuse, small, stunted, same size nodules. This is one of our patient papillary carcinoma metastasis into the lung 15 years later treatment of papillary CA. 15 years later. So papillary CA carcinoma can get metastasis to this. And recently also one of the paper published from the case from Metro Hospital Delhi. There was 20 years later patient developed very recent presentation they did, and this was 15 years later. There's only single nodule. Thyroglobulin was positive, IS is also positive, papillary CA. So this is a patient, middle-aged lady, came with pleural effusion, and she underwent further testing for the cause of pleural effusion. You can see large pleural effusion. There is pleural thickening. This patient underwent thoracoscopy. Thoracoscopy turned to be mesothelioma, malignant mesothelioma. This is the post-thoracoscopy images, near normal looking. So now what is to offer? We have staged the patient. There was right paratracheal single node higher up at the just above right side of the right vocal cord. Underwent screening ELS. We could not localize the lesion, and this patient underwent mediastinoscopy later, and mediastinoscopy proved that node is due to tuberculosis. This patient underwent ATT and took ATT and neoadjuvant chemo. Subsequently got operated. Patient underwent extrapleural pneumonectomy. This procedure was done by one of our teacher, Professor Arvind Kumar, the director of the lung transplant at Medanta Medicity, and you can see the post-pneumonectomy changes. She lived for 1.5 years before she succumbed to the disease. So this was malignant mesothelioma. So this is our initial experience of the thoracoscopy, which published in Lung India. So this is a very interesting patient, came with hemoptysis, bilateral disease, upper lobe dominant, and you can see aspergilloma, profusely bleeding, recurrent patient not willing for definitive bronchoscopic procedures, and you can see bilateral disease, aspergilloma. You can see aneurysm here, Rasmussen aneurysm, and the patient opted for the interventional procedures, and Dr. Muthraj embolized this with the device, and patient improved. You can see the device inside too. But patient, after 6 months came with recurrent hemoptysis, breadwinner, 30 years, single child of the family, bilateral disease. Which to operate is the biggest dilemma in pulmonary medicine when you have bilateral disease. But tracking the contrast, we decided to operate on the right side to the right upper lobectomy. Patient underwent. This is the lobectomy specimens. This turned to be combined mucor with aspergillosis, which ultimately formed a definite treatment for this patient. These are some of the mucormycosis colonies, which you can see this. This lady, very recent patient of Dr. came with abdominal discomfort, asymptomatic. Chest X-ray, there was miliary lesions in the CT, This is the laparoscopic view of this patient, laparoscopic image. Patient underwent biopsy from this peritoneal nodules, and these are the answers from pathologists. So this is very nice granulomas. This was tuberculosis. It's a very simple case. I just projected that to pass the message to the students that you can have lesion elsewhere with a diffuse lesion in a asymptomatic without any symptoms. So this is the significant improvement after 3 weeks of ATT. You can see. So you can also see the fundus for the choroid tubercles in these patients. You can see choroid tubercles. So this was miliary tuberculosis. This is a case referred by Dr. Karthikeya sir. Left kidney RCC, underwent radical nephrectomy. Patient came with left lung nodule. Tendency is to call that it is metastasis, but the tendency is not to call it is metastasis because of this appearance of the lesion, and there is early breakdown of the lesion. We did a biopsy. Muthraj did a biopsy. It turned to be cryptococcosis. So this was pulmonary cryptococcosis in a patient who had underlying RCC. Underwent treatment. You can see the improvement in the lesion with the antifungal therapy. So this is my last slide. I am going to stop here because we have interesting cases to present to you, but we have to stop here. And this is the last slide. This is the earliest, the ECMO services. The first time we did at our ICU for an unsuccessful patient at the terminal stage. The message is we have ECMO services, and these being offered in the CTBS OT. One of our patients who also underwent ECMO during the procedure for the catastrophic event. If there are no more questions, we pass on to the next presentation from Dr. Arun.
So this is the first case of a 55-year-old male. He had been diabetic and he had been on anti-hyperglycemic. So he came in with complaints of fever, cough, shortness of breath, malaise, typical symptoms of a community-acquired pneumonia with flu-like symptoms. So he was hypoxic on presentation and he was mainly he required low flow oxygen initially when he came in. Chest X-ray showed left upper zone consolidation. DBT showed typical type 1 respiratory failure. So this is the X-ray that he came in with initially. So he was put on empirical broad spectrum antibiotics. Initial workup, everything was negative, including the hemogram, routine liver renal function test. LV function was also found to be adequate at this point. So all the initial blood workup, all the culture reports, everything turned out to be negative for this patient. Usually sputum stains, mycobacterial stain, fungal stain, everything was negative at this point. So this is when we got the CT scan done. So you could see that consolidation not just in the left, even in the right upper lobes as well. So at this point, whatever we worked up for, all the thing was negative. So that, at this point, we contemplated organizing pneumonia. So we did all the rheumatological workup, RA factor, anti-CCP, CM copy, and everything turned out to be negative. So that is why we considered cryptogenic organizing pneumonia, and the patient was put on steroids. And prophylactic antibiotics was continued at this point. And the patient improved clinically, and oxygen was subsequently tapered and stopped. So you could see the serial X-rays after putting the patient on steroids. So many a times the point of contention is that many a times you do not need biopsy or even you do not need bronchoscopy. Bronchoscopy is plainly to rule out other microbiological causes, eosinophilic pneumonias. Biopsy, even if you do have to consider, you have to consider surgical lung biopsy. Many a times, bronchoscopy lung biopsy might not suffice. So it is one of the idiopathic interstitial pneumonias, and most often it is associated with other connective tissue diseases. Could be connected with other drugs, malignancies. When it is called a secondary organizing pneumonia, and typically it occurs in the 5th or the 6th decades of life with no sexual predilection. Often it mimics a community-acquired pneumonia. So many times patients present with typical symptoms of a community-acquired pneumonia in itself. So what we have to have is a high level of suspicion for all these cases. And invariably the X-ray or CT scan is going to show consolidation with ground glassing in the lung peripheries mainly. The treatment always remains prednisolone 0.5 to 1 milligram per kilogram to moderate to severe cases. For mild cases, even without this treatment, patient might do better after some time. As Nagan sir mentioned, many times the organizing even with the patient with rheumatoid arthritis, it might be pauciarticular. 15% of cases are pauciarticular, which means patient might not have any joint symptoms, but then patient might come with complications and sequelae of the underlying rheumatoid arthritis or whatever the patient might be having. So we'd have to have a high index of suspicion for these cases. We might have to even repeat RF factor anti-CCP and vascularity panel for these patients. So it comes with a huge list of primary factors. Organizing pneumonia can be due to all these factors. I'm sorry, the slide is not very clear on that one. So coming to the second case, it's a 54-year-old male with no prior comorbidities, and he came with complaints of cough, fever, and sputum reduction of 1 month. And he had 10 days of shortness of breath as well. So if you see the chest X-ray, it showed non-dissolving right upper zone infiltrate, and he had been put on multiple antibiotics by the local practitioner. So if you could see the right upper zone infiltrates. So at this point, we were contemplating tuberculosis, but then sputum was not really forthcoming. So we went ahead with the bronchoscopy. And what we could, to our strange this thing, AFP smear was positive, yes, but then the CP-NAT, the gene expert, came as negative. So what it means is non-tubercular mycobacterial infection, and patient was put on rifampicin, ethambutol, and azithromycin. And surely so, AP culture came out as Mycobacterium intracellular infection, which is a non-tubercular mycobacterium. And the patient was continued on rifampicin 600 milligram, ethambutol 800, and azithromycin 500. Patient clinically got better after 6 months, and the plan is to continue for at least 12 months, because even if sputum conversion does happen place after 2 months of this treatment, there's high chance of recurrence. So most often you would need at least 12 to 15 months of therapy. Talking, just a few words about Mycobacterium avium complex. It principally comprises of 3 organisms: Mycobacterium avium, intracellular, and chimeric. And it is categorized as 3 main things: whether it is nodular bronchiectasis, whether it is cavitatory, or it is both a whether it is more a fibrocavitatory disease. So in the case we saw, it was more of fibrocavitary disease. Why it is characterized into 3 main? Because the treatment principally determined, the treatment is based on the categorization. So for this patient was put on rifampicin macrolide and ethambutol, and additionally, if there is more cavity, there is more nodules, then we would have to add amikacin as well. So coming to the third case, it's a 55-year-old female with no prior comorbidities, and patient came with cough and shortness of breath of 20 days duration. She has no pets at home or no occupational exposure. PFT showed the restriction, and sputum again was she was bringing out sputum, but it was inconclusive at this point. So if you could see the X-ray, you could see the cavities in left mid-zone. You could see cavities. This is a CT image of the patient. You could see multiple cavities, not just in the left, but also the right as well. So multiple cavities in multiple levels, and lower down you could see bronchiectatic changes as well. So again, we went down the rabbit hole again with the plain bronchoscopy, and to our pleasant surprise, this came out to be nocardia. Usually we do not send out for a modified set and sphere, but in this case we certainly did. And all thanks to Dr. Rashmi and team, we got a nocardia specimen in this thing. And the patient was put on plain quatrimoxazole for 6 months, and patient improved. You can see the earlier lesions, whichever it was, the cavities, everything got better with the treatment. So nocardia, as such, it is a very uncommon but not very rare, and it is uncommon because it is not often thought about as well. So it is gram-positive and aerobic actinomycetes. It causes localized and or suppurative infection in any organ. Most often it does happen in an immunocompromised patient, but then again 1/3 are immunocompetent as well, and it can disseminate to any organ, CNS, you name it, any organ can be affected in this due to this. And as such, it has a high tendency to relapse or progress despite adequate treatment. So that is a problem. And there could be difference in susceptibility patterns for different species. You have different nocardia species. So most often, quatrimoxazole does remain the first line, but then you have amikacin, imipenem, meropenem, 3rd generation cephalosporin, minocycline, linezol. All these have been tried. Even combination have been tried, especially for CNS or multi-organ involvement. You would have to have a multi-antibiotic approach for these patients, and surgery would be required for some patients. Generally, the duration of treatment would be 3 to 6 months for CNS, or for multi-organ involvement for at least 6 months. And for immunocompromised, you would have to have a longer regimen. Coming to the fourth case, a 58-year-old with no prior comorbidities. Patient had been a chronic active smoker. Patient came in with cough, shortness of breath of 15 days duration, and the chest X-ray showed a very high opacity. And patient had been taking multiple course of antibiotics from multiple practitioners and bronchodilators from multiple places. That is when patient came in, and this is the X-ray the patient came in with. Left, you can see the left mid-zone opacity. Sorry, I don't have a pointer. This is the mid-zone opacity, not very clear. Okay. So we got a CT done. It showed showed a nodular opacity in the left upper lobe. And then what we did was so CT showed a mediastinal lymph node as well, a left hilar mediastinal lymph node as well. So we went in, we got a biopsy from the left. You can see the concentric pattern of the radial EVIS probe on the left hand picture. So that is where when you have a typical mass-like structure and the bronchus and the scopy is going in through the mass, then that is when you have the concentric-like picture. And then you got a biopsy from the same. At the same sitting, because the patient was already under, we went ahead with a left hilar lymph node biopsy as well. So we got a linear EBUS done for the patient. The earlier, the peripheral lesion, we got a radial EBUS, and the same patient, the same sitting, we got a linear EBUS for staging as well. So to our surprise, at the same sitting, so I'll come to the report after showing the PET-CT report. So PET-CT, what it showed was there was no uptake anywhere else, no mediastinal lymph node uptake. Apart from the primary tumor, there was no uptake anywhere else. And unsurprisingly, the biopsy report came in as adenocarcinoma. Even the mediastinal lymph node showed N1 this thing. Mediastinal lymph node was positive in this patient. So what is the lesson is that even if the PET scan is negative, you might have to go ahead with getting a biopsy from the left, from the N1 node at least, because many a times even the PET scan does skip out the lesion, the EBUS might pick up the lesion. So you have to upstage the disease. The treatment itself is going to be different for that patient. So a word about linear and radial probe EBUS. So linear EBUS is used to diagnose peripheral pulmonary, mediastinal lesions, and radial probe is used to reach peripheral pulmonary lesions or nodules. So it is used to for active staging of lung cancers, and it is used in conjunction with PET-CT. So nothing replaces the other. So it is used in conjunction with PET-CT. And the advantage of all these EBUS probes is that it is minimally invasive. So relevance of EBUS with negative PET. So this detection of false negative results on PET scan, you can pick it up with an EBUS. You can do accurate staging, and even for cases where PET-CT might miss out on, like for example sarcoid, when the PET-CT might miss out on, you could pick it up from EBUS. So I'd like to end with this slide. So prompt referral is the key in all these cases. Multidisciplinary discussion is often required with a multimodality approach, often requiring CT scan, radiological. You'd have to get your colleagues' help from radiology, pathology, microbiology. Invariably, judicious use of antibiotics and antibiotic stewardship is a need of the hour at this point. So I'd like to end with this slide. Thank you.
So any questions?
Any comments? Any questions?
Yes, this is my own doubt. So both of you, the patient being treated for pulmonary tuberculosis with the ATT for the past 6 months. Now the patient comes with, she is a known case of seizures also. She has idiopathic GTCS. Now the patient comes with the post-ictal stupor. She continues to be in the state of unconscious state for the past 2-3 days. And this time serum enzymes elevated and bilirubin is also elevated. This was an ATT, so we had to stop temporarily this ATT. But sputum continued to be positive. I don't know how. Okay. In this setting, meanwhile she is developing fever, etc., maybe a nosocomial infection. She continued to be in the coma stage, and enzymes elevated all the time. How to continue with the reformation or what? Along with other antibiotics.
So you have proven, microbiologically proven sputum positive pulmonary tuberculosis. It was drug sensitive tuberculosis or drug resistant tuberculosis?
Drug sensitive, mostly. I didn't know that.
Okay. So presumably, if it is a drug sensitive tuberculosis, I think so. So presently, if there is a DA, drug-induced hepatitis, you have to modify the ATT. Number two, and once the liver function is improved, we always reintroduce all the drugs.
Not improved. Continue to be deteriorating, and ultimately we lost the patient. And
So you have to,
sepsis-
we have to definitely,
sepsis-
we have to definitely modify the ATT. There is no doubt about it. And coming to her first question, she's continued to be AB positive. That's what you mean.
I think so, because start with the ADT because AFP positive. Then after admission also AFP seemed to be positive.
How many months after starting?
6 months.
6 months. So that
So
is
6 months means if it is drug sensitive, would this be positive for the past 6 months?
unlikely, sir. So that is why those guidelines have gone away. The present dictum nowadays is to test all tuberculosis for drug-resistant tuberculosis. All sputum samples should be submitted minimally for gene expert and line probe assay to detect rifamycin resistance and the isoniazid resistance, and also to send, preferable to send one culture for the AAV culture sensitivity. One. Number two, presumably, I also think that if AAV is continuing to be positive, if the gene expert is negative, if I think, then it can be an NTM also, not because we are not told what is the radiology is. So what could have been done to answer to your question number one is to send all these samples for testing drug resistance pattern. One. The message for the students is if the AAV smear is positive, gene expert is negative, that is alarm bell. That's where you have to start thinking. Can it be anything else other than the mycobacterial tuberculosis? Can it be MOT? And thirdly, for the learning point of view, there are so many other organisms which can stain positivity in AAV smear, like nocardia and so many things. So we have to look into that.
No, what we thought here is simple tuberculosis meningitis. It was not so. There will be lumbar function normal, CSF study normal. It's unlikely to be meningitis. And initially she was rather improving. First 5 hours, 7 hours. After that, they started having ice bathing fever. Then never came down. Then we lost her.
It is drug sensitive tuberculosis scenario is very unlikely, sir. The subsequent things can be discussed and evaluated. Good.
Thank you.
Good morning, everyone. I'm thankful for this opportunity for the presentation. This is my first presentation here. And after the clinical scenarios with storming presentation by my seniors, I'm just taking up the topic of bronchial asthma, some challenges which we face in diagnosis and treatment. So bronchial asthma, as we say, it's said to be a more common diagnosis. Most of them with the breathlessness are said to have bronchial asthma, presumed to have bronchial asthma, and they are treated or they are on regular treatment or on irregular treatment, whatever it be. So misdiagnosis of asthma is more common in many places because it's not easy to diagnose asthma, and sometimes the very important thing is that in case of underdiagnosis or overdiagnosis, whatever it be, it has its own impact. In case if it's underdiagnosed and not treated properly, then they'll be having to face all the morbidities and mortality which could be easily treated and they can be saved. Or in case if they are overdiagnosed and it's not an asthma, they'll be loaded with lots of inhalers, nebulations, and steroids and other things, which will lead to the medical as well as the non-medical costs and having an impact on the quality of the life of the patients. And this occurs even in the countries which are said to be the developed nations in the world. And for a few reasons which leads to this confusion or the misdiagnosis are, one important thing is that asthma is a variable condition. So it will not be having the persistent symptoms or they will not be having the same manifestations all the time. Sometimes they may be asymptomatic, sometimes they will be having severe symptoms. And regarding the test for the diagnosis, spirometry is the most commonly used test for diagnosis of asthma. And in case if the patient is asymptomatic or he is doing well when he comes for a consultation, then that time the spirometry may be normal and he may not be treated for asthma. And certain tests like provocation tests are being done, but sometimes the patients may not tolerate or they may have a severe hypersensitive reaction, hyperactive airways. So most of the places it's not done. And another important reason is due to the large caseload or due to the short of time, in many places we are not able to follow the protocols to diagnose the asthma. And this gives the GINA definition for asthma. And a few important words which we need to consider here are, it's a chronic airway inflammation, and it's very important to decide the drug of choice for treatment for asthma. And here the most common symptoms, as you all know, is that wheeze, shortness of breath, cough, chest tightness. And other important thing is that it varies over time and intensity. That's the important thing which makes the difference in the diagnosis for asthma. And these symptoms may be triggered by various features like allergens, pollutions, irritants, and changes in the climate or weather, and when they are going for an exercise or an exertion. And sometimes with viral infections, they have increased symptoms. And many of them will have the reversible symptoms, so they will be just back to normal, sometimes even without any treatment, or sometimes they may have a severe exacerbation that may be life-threatening. So when I joined here recently, I had a patient who was admitted here around 15 to 20 years before when Dr. Mountmaster was here. She was admitted at the age of around 15 or 16. And when she showed the discharge summary, it was written as bronchial asthma with the type 2 failure. She had a severe exacerbation that she was intubated, ventilated, and she was treated. And the thing is that after 1 or 2 visits, she has lost to follow, and then again she has developed the symptoms in between. So she has not done regular medications and other things. And the reason behind this topic is that it has got its own economic burden, both as well as the medical and non-medical costs and direct, indirect costs in treatment of asthma. And main goal is that we just need to have an appropriate diagnosis and proper treatment control, good control with a good treatment. So the stigma of asthma diagnosis, many people doesn't like to have or doesn't like to hear that they have a diagnosis of asthma. So that's a very important thing. They consider it to be a social stigma that they don't like, or they don't even believe that they have an asthma, even in spite of having severe symptoms, which make them to go to hospital frequently. And this stigma implies the asthma control because they don't go for regular treatment or follow-up, and they don't use their inhalers or the proper medications. And recently, in a study from India, they were documented that compared to the previous decades, the stigma is gradually coming down, and the adherence to the treatment things are improving, and the patient follow-up is also good. And regarding the challenges in the diagnosis, spirometry is the most commonly used test. And some of the limitations which make the spirometry could not be a definitive diagnostic tool is that primary thing, the disease per se. It's a disease with variable symptoms. So as I said, in case if the patient comes to us with no symptoms or when he is comfortable, then the spirometry may not be having obstructive component which is being clearly shown with the bronchodilator reversibility. And another thing is that spirometry is effort dependent. So the patient needs to have a good coordination. They just need to have a good effort. They need to have a deep breath and then blow it continuously at least for 6 seconds. Then only we'll be having a good spirometry to have a diagnosis. If not, we'll just need to say this will be an inadequate effort and will not be able to appreciate the bronchodilator reversibility, which is very important to differentiate between bronchial asthma and COPD. And we have got a lot of contraindications like recent surgeries, recent MI or cardiac events. And when the patient is not able to move along or the patient is not able to sit and they are not able to perform due to any other facial injuries or so. And another very important thing is that we just need to have a well-trained technician who needs patience to make the patient understand and then to perform the test. In case if the technician is not having adequate patience or he or she is in a hurry, then they will not be able to explain clearly. Even if the patient is able to do, they will not be able to completely deliver the full effort. And FeNO, this is fractionally exhaled nitric oxide. This one indicates an eosinophilic inflammation which is occurring in the airway. And in case if it's high, we just say it to be a supportive evidence for diagnosis of asthma. But in many cases, it may not be supportive because there are conditions where even without asthma, they might have increased levels of FeNO, or some conditions with some patients who have an asthma but not having elevated FeNO levels. For example, those with allergic rhinitis, eczema, eosinophilic bronchitis and all, they have increased levels of FeNO. In the same way, in case if the patient who have asthma phenotypes like neutrophilic asthma or asthma with obesity, then they may not have increased FeNO levels, so we can't say that they don't have asthma. And GERD, this gastroesophageal reflux disease is another important mimic, which is of great importance because we don't have clear differentiation by the symptoms which is being given by the patients. So some studies say that the vagal nerve innervates both esophagus as well as the tracheobronchial tree, contributing to the pathophysiology involved in asthma and GRD. So in the studies, the installation of acid has shown to have a decrease in the peak expiratory flow rates on PFT with increased overall airway resistance. So when you're just extrapolating to the clinical scenario, in case if they have frequent regurgitations with micro aspirations, it might have an impact on the airway resistance, and also they will have a sensation of breathlessness or difficulty in breathing, chest tightness and other things. which makes it difficult to have a diagnosis for asthma. And vocal cord dysfunction. So it's known as the paradoxical vocal cord fold motion, and it's an abnormal motion of the vocal cord which is occurring during the respiration. Most commonly, the vocal cord gets adducted, and it's more common during inspiration. So these patients are also who are having the same presentation as like the asthmatics. They will be having shortness of breath, tightness of chest, hoarseness, voice change, stridor, and all things. So the important differential thing is that they will not be having a proper response or adequate response to bronchodilators or inhaled corticosteroids, and most of them don't have the symptoms during sleep. So this can be triggered by acid reflux, postnasal drip, or tobacco smoke exposure and other things. Usually the spirometry and the laryngoscopy help us to have a diagnosis, and here mainstay of treatment is by the speech language pathologist or the speech therapist who teach the vocal cord relaxation techniques and the breathing exercises. So this image shows that vocal cord is being erected in the inspiration, as a result of which it shows a change in the inspiratory curve in the PFT. And laryngoscopic examination, when the patient is having the symptoms, will help us to identify this obstruction. In case if the patient is asymptomatic, once when he is presenting to the OPD, then it again makes the diagnosis difficult. And some other asthma mimics are the cardiac conditions like heart failure or pulmonary edema, and COPD with non-smoker COPD more common in females in many places, bronchiectasis and viral bronchitis. These patients also usually present with complaints of breathlessness, chest tightness, wheeze, cough, almost similar to that of asthma. So what are the challenges we face in management of asthma? Some of the challenges in asthma are mainly the over-reliance for short-acting beta agonists or the SABAs, which are being prescribed for initial treatment, and under prescription of inhaled corticosteroids, non-adherence to the treatment, and inhaler techniques. And one important thing is that asthma control per se, which is being given or which is being directed by the guidelines like GINA, are not applicable to all the patients. It depends on own patient's perception. So for a patient who is very breathless and not able to walk even for a few meters to go to washroom, the inhalers which gives release to move to washroom will make him feel that he's doing well and his asthma is well controlled. But it is not the actual thing. They have the asthma still and be having its own impact. And for some of them who have very minimal dyspnea, which makes them to say that I am feeling very tired, I am not able to move, I have got a chest congestion and I am having severe wheeze. So the perception by patient makes it difficult to have a scaling for the scale of scoring for the asthma control. And these are some of things which show the poor asthma control, like over-reliance of SABAs, adherence, non-adherence to medication, inhaler techniques, smoking, obesity, misdiagnosis, and lack of routine follow-ups. So, short-acting beta agonists are very important medications which play a great role in the treatment of asthma for immediate relieving of symptoms. They are used as the reliever medications. But the thing is that many of them are using the SABAs as their prime treatment. Since it gives an immediate prompt relief, they prefer to use SABAs than the long-acting controller medications. Because of this drugs being available as over-counter drugs, it's easy to get and they need not come for a prescription for a revisit. They just immediately go, say the name, get the inhaler, and then they continuously use it for a long time. And when they are using it for a long time, they have some side effects like tachyarrhythmias, tachycardia, hypokalemia, anxiety or tremors. And this long-term use of SABAs may lead to have an impact on the treatment of asthma because they don't have any anti-inflammatory effect. As I said in the starting, asthma is a disease with chronic inflammation. So it's not addressed and it's not treated. Hence, the asthma will not be treated and it will not be controlled. It will just go for some time and then again peep up again. Lack of ICS. So the fear of using steroids, that's a very important thing. So whenever we say that asthma needs to be treated with steroids, that will be helpful to control the symptoms. People immediately say that, "Ayyo doctor, venda, steroids venda." No, steroids na uthukada kedudal nariya padichirukken ketirken. But that's not the thing. It needs to be given. So the thing is that many of them don't worry to eat a shawarma 3 to 4 times a week, but they are more concerned to use ICS, which is having very minimal side effects or not even having the side effects which is concerned to have the oral corticosteroids. And another important thing is that some of the healthcare professionals also are not able to identify the need for inhaled corticosteroids or the benefits with the inhaled corticosteroids. So in the primary care, they are given with the short-acting beta agonist. With that, the patient moves all around. Early initiation of low-dose ICS has a greater improvement in the lung function, and the patients not taking ICS have a severe exacerbation rates, which is very severe than that compared to the of patients who are on regular ICS. So this image shows the impact of ICS. So when inhaled corticosteroids are inhaled, it goes through the airway epithelial cells, and it has these all benefits, which ultimately leads to a decrease in the inflammation in the asthma and having a good control for asthma. Non-adherence to inhaled medications. As like any other medication, there is a great non-adherence for this asthma medications, primarily the inhalers or the other control medications also. And more commonly, this non-adherence is noted in patients who are having asthma for more than 3 years. Meaning that I know asthma, asthma, that's the attitude many of them have. And some of them with age more than 40 years and due to lack of education. And some other reasons are that they don't have an adherence mainly because not really willing to use inhaled corticosteroids. They prefer oral tablets, or they prefer or they believe that the herbal medicines or other things will be of good control. And they are not willing to carry inhaler because it's a social stigma. And regarding the inhaler technique, this is one of the greatest tasks which we face when we are treating the patients with asthma or COPD. So this image shows this n number of inhalers. So as like when we just step into a mobile shop, we are having a different mobiles with different models. We have got n number of inhalers these times, and we just need to decide on what is the appropriate inhaler for the patient. We just need to discuss with the patient. So it's usually done in the pulmonology OPs. We just assess the patient status. We decide whether he needs a tricoder inhaler or a meter-dose inhaler, or in case if he is having severe symptoms, we just consider to go for an nebulations. And just a few minutes to show few of the inhaler techniques. So this is most common thing. This is the meter-dose inhaler, which is being used in many places. So thanks to the movies and the other things, because many of them are familiar with this kind of inhalers. So whatever be the reason for breathlessness, they go to a medical shop, they ask for inhaler, they just take it. The thing is that we just need to use it with the proper spacer device for adequate deposition of the medicine. So for demonstration, so this will be the force with this medication will be coming. In case if the patient is directly using this by keeping like this, the most of the medicines will be deposited in the throat and the oral cavity than being delivered into the deeper parts into the trachea and the lower airways. So for that, we usually suggest them to use with this spacer device. So just need to ask them to put it like this, and then hold it with the chin up, and then have a press, and after that inhale deeply, hold the breath, and after that we just need to exhale through the nose. This is more commonly suggested for meter-dose inhalers. And the other one is that the tricoder inhalers, this is one kind of device. So here the thing is that we just need to put the capsule inside and then close it. So when you're just pressing, we'll be having the needles. So this is just to make you that I'll be able to reinforce the information which will be helpful for you to treat the patients. And then we just need to ask them to hold it and then have a deep breath, hold the breath, and after that exhale. So very important thing which we need to notice in this, that many of them will be having these capsules which they'll swallow it and then they'll come back and say that we are not able to have the relief of the symptoms, it's persisting. And some of them, instead of having a deep breath and holding, they'll just have it. So this will also be of not much benefit to have a deep inhalation. And recently when I had a discussion with one of my friends, when we were just simply discussing, he said that one patient he was on an inhaler for quite some time, but repeatedly was presenting. I consulted 2 or 3 people, and she was an inhaler saying the symptoms are not relieving, and he had been on triple drug therapy also. And finally, that was the time she presented to him, and when he asked the patient to demonstrate the inhaler technique, she used to say many things, and then she was not convinced to demonstrate that inhaler technique before the doctor. But he just said that I just wanted to know the inhaler technique. If anything needed, I will be able to help you. And everything was done perfectly. She opened it, put it like this, everything was done. And after that, she did sit like this and then did it completely. So the reason was that mixing inhaler use inhaler. That was the answer given. So the inhaler technique plays a very important role. Whatever needs to be given, which needs to be given in a proper way, will be of great use in the treatment. And preference for oral or alternative therapy or prefer than inhaled therapy. As we say, we are not interested to use the inhalers. And concerned to the females, actually it's really a problem. Many of the young girls who are diagnosed with asthma, their parents' concern is that if she is said to have asthma and if she is taking inhaler, will it be an impact for her marriage proposal or prospects? That's a concern that many of them don't take. And in case if they are not on regular treatment, after that they'll end up in trouble and they have severe exacerbations because of improper treatment or a lack of treatment. And embarrassment and using the inhalers, and also for the youngsters when they are having symptoms and want to use inhalers among their peer groups, it makes them to feel low and they feel depressed and more anxious. These are some of the reasons, and they prefer to go for alternative therapies like herbal medicine, fish therapy or acupuncture, where they put the fish with some medications and it's given I think once in a year, and lots of people go for that kind of treatments also. And smoking as such itself has a great impact. It's a reason for development of COPD, and for the patients with asthma also, chronic smoking has its impact, and it doesn't have a good control for asthma in spite of taking regular medications. And avoidance of triggers is very important. So some of the indoor triggers which we easily forget to address or which we don't consider are mainly pets, house dust mites, rodents and cockroaches, and indoor air pollution. So this image shows some of the causes for indoor air pollution like chullas, tobacco smoke. In case if an adult smokes in the home, even the child might have an impact on it. And that's with the mosquito repellents or the mosquito coils, agarbattis and other things, they all have its impact. And these are the things which have triggers frequently, and patient is still symptomatic in spite of regular treatment. And in this month, we just have World Asthma Day, which was observed on May 7th. And the theme for this year is that asthma education empowers. Yes, that's true. So asthma education is very important to have a proper diagnosis and a good treatment, thereby having a good quality of life and improving the patient's status. Thank you.
Thank you, Krishna. So any questions? Yeah.
We believe that like activities like swimming, all that will help improve asthma. Is it true? Like, just wanted to know whether it is a myth or.
No, it is not a myth. It does help. Even it is inscribed in the GINA guidelines that swimming should be taken up as an exercise for the proper control of asthma. It brings down the weight, brings down the improves the exercise, the symptom control. It is not a myth, it is actually.
It is true,
It is
right?
true. It is.
Because that's mainly for the postgraduates here, because my son had the problem, and the doctor, the earlier pulmonologist before Logo, and then he advised he has to have a reduction in weight, and swimming really helped him. Like he was almost symptom free, and he's now in college, so we are very happy about the results.
Only thing
So,
they would
maybe
have
the
to,
consistency.
yeah,
right?
the only thing they would have to be wary about is the chlorine in the water itself can be trigger for some.
Triggering,
And second thing is exercise can be this thing for asthma. For some people, for them, it is better that they carry an inhaler prior to the exercise. But then, if they get used to the exercise, nothing works better.
Thank you.
Yeah. So, but if they take inhaler properly, they can swim prolonged periods.
True.
So there is something called EAE, exercise-induced asthma. So that they can this we see in athletes, footballers. And there are some cricket players who take asthma, the inhaler also.
Yeah.
So recently I had a patient, the marriage, since to add the flower to the presentation, young female, asthma, well controlled. She was taking inhalers. This marriage engagement got over 1 year ago, and she came by weeping, month ago, saying that the marriage got terminated because she had to use inhaler devices. She came a couple of days before bringing her fiancé. She got engaged. So there are patients who actuate the inhalers in the air and they catch like this. They go. There are patients who actuate the inhalers in the axilla. And they inhale. So, one of the funny and interesting part in asthma, the lectures are the faulty inhaler techniques. So, we always enjoy those talks. What if you take any severe asthma, the talks, difficult asthma or severe persistent asthma, commonest and commonest and commonest and commonest is poor inhaler technique. It is a global problem, not only the Indian problem. So that any severe asthma treatment ends by addressing these issues. So it cannot be overemphasized the importance of using inhalers.
So, for instance, sir, if the patient is prescribed with an anticholinergic like glycopyrrolate with ICS or ICS with LAB or SAPA, so which should be given first? So, is there any protocol that steroid should be given first or?
Jonas, you want to take up the question? There are different guidelines on that. So you are discussing with different molecules. You have ICS, you have beta-2 you have the anticholinergics. There is definite answers to this. The first line treatment is ICS. He was addressing to. The question of triple therapy is to I do travel with a case of asthma in which stage what kind of molecule you require depends on that. To answer the question straight away, it's not the anticholinergic that should be used first, except certain subsets of post-infectious cough, which will not come under asthma. So there are a lot of studies on anticholinergics.
So one more question. So sir has mentioned about this use of inhaler through spacer. So we have some discrepancy that the ones when the inhaler is once after one puff, then how much time the patient should inhale and exhale through the spacer?
So usually we say that once when we are just activating the puff, it needs to be kept. They need to have a deep inhalation, hold it for 10 counts, and then breathe out through the nose. We say at least 3 to 5 times they need to have a deep breath, repeat the maneuver. Then only it will be of proper delivery.
So it should be immediate.
Thank you.